There was no history of dyspnea, wheeze, hemoptysis, stridor, chest pain, hoarseness of voice, or dysphagia. No history of fever, rigors, and night sweats. No history of weight loss, fatigue. No history of shoulder or arm pain, facial or neck swelling, and giddiness. There's no history of swelling of lower limbs and pain, and no history of paraneoplastic manifestations. Next slide. There's also no history of headache, seizures, vomiting, abdominal pain, soft tissue swellings, bone pain, or limb weakness. He was seen by a physician and referred to a center for further management. Past history. There's no similar illness in the past. He has history of diabetes mellitus for the past 10 years and he's on Ayurvedic medication. He has history of hypertension for the past 10 years and antihypertensives. No history of tuberculosis or contact with tuberculosis. No history of unresolved pneumonia, connective tissue disorders. No history of dyslipidemia, CAD, chronic kidney disease, liver disease, COPD, bronchial asthma. No history of previous hospitalizations or surgeries. No history of malignancy, treatment with chemotherapy or radiation. Drug and allergy history. He's on antihypertensives. No history of usage of inhalers and non-prescription drugs. No history of drug allergy or any other allergies. Next. He has normal sleep and appetite. Bowel and bladder habits are normal. He consumes a mixed diet. He is a chronic smoker. He started smoking at 30 years and stopped 5 months back. He consumes 1 pack of cigarettes per day for 33 years. He has occasional alcohol intake, that is 1 to 2 pegs per month. He is married with 2 children. Next slide.
Pallavi, why did you say cigarette 1 pack per day? So what do you mean by this cigarette pack here?
Pack here is the 1 pack is estimated to have 20 cigarettes, and the total number of packs per year, packs per day into the number of years smoked is a total pack. Yes.
So you think the patient, this particular person is having a low pack years or a moderate pack years or a heavy pack years? What is the criteria like that?
He is a moderate pack years.
What is the cutoff for?
More than 60 pack years is heavy smoker.
So what is this moderate then?
Moderate more than 30 pack years.
I thought it is 20, 40. 20 is low, below 20 is low, and 20 is moderate, and more than 30 is heavy. Varun, you want to contribute anything?
Yes, sir. So Dr. Pallavi, so what do you mean by chronic? Is a term called chronic smoker? Is it a standard terminology?
No, it is not a standard terminology. Standard terminology is a recent smoker, active smoker, a former smoker, and never smoker. That is.
Yeah, the standard terminologies are either the former smoker, or ex-smoker, or the current smoker.
He's a former smoker.
Okay. Do you think is there any relationship with smoking and the present problem?
There might be a relationship with him being a chronic smoker, because chronic smoker increases the probability of the chance of malignancy, and also it leads to other. It also aggravates other disorders like COPD. And
so this history in what all ways will help us in the planning our treatment, if at all it's a malignancy?
History-wise, since he has complaints of cough and loss of appetite, and since he has no fever or any other systemic systemic manifestations of infection, it might be due to malignancy. And since he is a smoker, from the history, it might be due to a central lesion.
Why it is a central lesion?
Because if there is endobronchial obstruction, can lead to cough.
So
So
actually
you
your
think
history is not actually correlating with your explanation. If it is a central lesion, usually patients will have bronchoria, right?
Mhm.
So is there any other problem like do you think that this patient is prone for chronic obstructive airway disease, and that is going to be a big problem for our treatment if at all he is going to be diagnosed with lung cancer? What do you think?
It is it may be a problem because if the patient is undergoing surgery, then adequate lung function, pulmonary function test should be adequate for him to undergo surgery. It's a major resection.
Any other thing like chronic obstructive airway disease is going to affect the functional outcome of a particular treatment when you are planning?
It can also affect radiotherapy.
Yes.
So
the radiotherapy also, he is at high risk for pneumonitis as well. And one more thing, the recent advances in the treatment, and one observation made recently was one particular type of treatment is going to be more effective in smokers. Can you tell us what I meant by this therapy?
immunotherapy.
Yeah, so what do you think that the immunotherapy is going to be more effective in the smokers or non-smokers? And what is the reason?
In smokers, there is EGFR mutations are less, and immunotherapy is more effective in patients with no EGFR mutations.
Smokers will be harboring what type of mutation rather than the EGFR?
Smokers will be harboring RAS mutations.
RAS mutations. Okay. So, Varun, I want to ask anything more about smoking?
Yes, sir. So Dr. Pallavi actually leave out this patient. Suppose if a person with more than 30 years, if a person comes to you for a consultation as an oncologist, will you advise training for this person, considering his smoking history? Will you advise any type of screening for him?
If the patient is more than 50 years of age, more than 55 years of age, and if he has and if he has not stopped smoking for the past within the past 15 years, then he is eligible for screening with low dose CT.
So what is the update on the screening for lung cancer in a high risk patient? Same thing, but as asked just now only asked.
Yeah, suppose if that person asks you, to you, doctor, what is the radiation hazard of a low dose CT? Then how will you explain that? Can you compare it with X-ray and the standard dose CT?
For X-ray, the radiation exposure is 0.1 millisievert. For a low dose CT, it is about 1.4 millisievert, and for a normal CT, it is about 78 millisievert. So if a patient is undergoing regular screening for 10 years, then the total exposure will be about 13 millisievert. So it is
very good.
So we can.
So what is the technique of doing low dose CT? Means how it is being done?
I'm not sure.
Yeah, actually it should be done within a single maximum inspiratory hold. That is, it should be completed within 25 seconds. So that is the difference between low dose CT and standard dose CT. Yeah, please proceed.
Family history, there is no family history of malignancy. Occupational history is a retired police officer, and there is no history of exposure to asbestos or other chemicals.
Since we are talking about lung cancer, do you think family history matters much?
Family history, there is increase in relative risk if there is one first degree relative or more than one first degree relative. there is one first degree relative with lung carcinoma, then the relative risk is 1.6, and if there are more than one first degree relatives, then the relative risk is about 3.6. So
what type
families,
of histology they have generally? There is a familial or when more than one members are affected in a family.
adenocarcinoma.
Okay. So can you just summarize before going to the general examination? Just summarize the history.
A 64-year-old gentleman who is a former smoker and who has no and who has a history of diabetes mellitus and hypertension, was evaluated for cough of 3 months duration, which is not associated with dyspnea, stridor, hemoptysis, no history of fever or any other or any other evidence of systemic infection. And in past history and family history, there is
So summary, yeah, it's only summary. Okay, you can proceed. So from the history, it looks like a 64-year-old gentleman with chronic cough, and we are going to examine further and to get some idea about this problem. Okay. So general examination.
general examination. Patient was examined in a well-lit room with consent. He was conscious, cooperative, and well-oriented with time, place, and person. He has an ECG performance status of 1. Height is 168 centimeter. Weight is 76 kg. BMI is 26.9 kilogram per meter square. Body surface area is 1.88 meter square. On general examination, he has grade 1 clubbing, no pallor, icterus, cyanosis, generalized lymphadenopathy, and edema. Skin, hair, nails, and thyroid is normal. No facial or neck edema, subconjunctival hemorrhage, dilated veins or papilledema. No evidence of Horner syndrome, and no extremity wasting is seen.
Why did you look at all these things like Horner syndrome?
Horner superior sulcus tumors can cause Pancoast tumors can cause Horner syndrome.
Okay.
And extremity wasting is also seen in
But
superior
he doesn't
sulcus.
have any pain radiating to the arms, and
No,
he doesn't have.
no, he has no history.
So then what is the importance of the subconjunctival hemorrhage?
In superior vena cava obstruction, subconjunctival hemorrhage can occur.
Okay, so he doesn't have any features of superior
Superior
vena cava obstruction. Or can you expect subconjunctival hemorrhage in any other condition which is relevant here? You get sometimes in very severe cough, a sudden bout of cough will produce subconjunctival hemorrhage sometimes. And why did you specifically mention about this thyroid is normal? What is the reason?
Thyroid with rectosternal extension can cause cough and facial swelling.
Okay, so vitals, anything? Then we will skip this.
Vitals, everything is normal.
Okay, so coming to the examination.
Respiratory system examination. On inspection, chest is elliptical, bilaterally symmetrical. Movements are also symmetrical. There are no operative scars, deformities, chest strain, lumps, or sinuses. There is no fullness in the supraclavicular fossa. Next. On palpation, there are no swellings in the supraclavicular fossa or axilla. No chest wall tenderness. Trachea is central. Cardiac impulse is felt at the left fifth intercostal space and midclavicular line. Chest wall expansion is symmetrical. There is no surgical emphysema. Vocal primitus is felt equally in all areas.
Okay, well, percussion, nothing much to tell about percussion. So we will go to the auscultation part.
Auscultation air entry is bilaterally equal. Normal vesicular breath sounds are heard. There are no added sound. Vocal resonance is equal in all areas.
So it looks like the auscultation is also normal. So what do you think this patient has got? Can you make out something from the examination?
No, sir. It might be a very small lesion. There are no examination findings.
You don't have any clue regarding what he is having right now?
Only clubbing is there, but
So other systems also.
other systems are also normal.
So what specifically, what other thing you will see here, right? Now, when you are suspecting a patient who is having lung malignancy, what specific things you will be seeing for the other systems?
For CVS, we can see if the cardiac if the S1 S2 is dull or not, because sometimes it can present with pericardial effusion. In GA examination, if there is mets to liver, then patient can present with hepatomegaly or an epigastric lump. Then in CNS, skull and spine, if there are bone mets, then the patient may have bony tenderness, and also if there is spinal cord compression, patient can have paresthesia or paraparesis or paraplegia.
Okay, so will you be able to make out if there is a diaphragmatic paralysis clinically? Can you suspect diaphragmatic paralysis by looking at the respiration?
It will be abdominothoracic.
It's going to be paralysis can occur only in one side, then there can be any paradoxical movement, which is more significant. So what does it signify actually? If there is a paradoxical movement and you are suspecting a diaphragmatic paralysis, what impression you are going to get from that particular single observation?
It is a T3 lesion.
Good. Mediastinal involvement and Varun, anything you want to add at this stage?
No, sir. Actually, we can proceed.
Yeah. So summarize.
65-year-old gentleman who is a chronic smoker, former smoker, history of diabetes mellitus and hypertension, complained of cough of 3-month duration. Examination revealed a grade 1 clubbing.
So what do you think this gentleman has?
Examination was normal. Considering the age of the person and age of the patient, and since he had a smoking history and he has clubbing, it could be a malignancy, lung malignancy, commonly at this age.
Okay, so smoker, we can call him as a heavy smoker. So a heavy smoker and a diabetic hypertensive patient of chronic cough must be with the examination only finding is grade 1 clubbing, might be having lung malignancy. That is what you are thinking, right? So what simple investigation you will ask at this stage?
We will ask for a chest X-ray.
So you have any chest X-ray? Since you haven't got the chest X-ray, I thought I will just put this X-ray. So what do you think this X-ray is?
Chest X-ray peer view, which shows a radiopaque lesion in the right lower lobe. There is no pleural effusion. There is no medial widening.
So what do you think this patient has got? Imagine that this X-ray belongs to your patient. So what is the likely chance that this patient is diagnosed with lung malignancy? More than 90%, right?
Yes, more than 90%. Lesion is more than 3 centimeters in size.
So when you get an X-ray of, or when you go for screening and the patient is screened for some other symptoms, and you are getting a lesion like this, what do you call this lesion?
Solitary pulmonary.
So what is the definition of solitary pulmonary nodule?
Solitary pulmonary nodule is a solid nodule which is less than 3 centimeters and it is surrounded by a normal aerated lung. Okay,
not associated with any proliferation or anything, right? Okay. So So how will you proceed? How will you decide whether forget about the history of this particular patient, because he is a smoker, and otherwise the X-ray is showing this. How will you assess the risk? And
Um, we will proceed with the CT of chest, abdomen, and pelvis.
what I'm saying is, you before going for a CT, how will you assess the risk for this particular patient? Why do you want to do a CT and find out? Because if the patient comes to me and patient has got certain risk factor, which I feel that it's important and relevant for malignancy, then I will be proceeding with in a different way. So tell me what are the risk factors which will guide you to decide the further investigation.
If the patient is a smoker, if he has a family history of first degree relative having malignancy, then
more than that, the feature of this radiological feature of this lesion.
It is not a rounded or it is not a rounded lesion. It is
Solid, speculated, or something like
it is
that.
a solid speculated lesion.
So if there are similar lesions, the patient is at a very high risk for that. So what are the risk factors? So these are the risk factors. Like if the age is less than 45, probably he has got low risk. So similarly, if you look at as a smoker, the patient has got high risk. So if the patient has got a high risk, what investigation you will ask for further? Do you still ask for a CT scan and then decide, or what would be your approach?
We will still ask for a CT scan.
CT scan and okay.
Mhm.
You will not ask for a PET CT and bypass the CT and go.
We can ask for a PET CT, but even if we can ask for a PET CT, but
Varun, you want to ask anything?
even
Yeah, in the case of a solitary pulmonary nodule, if it is high risk, actually the investigation of choice is PET scan.
So you don't have to wait for because the risk is very high, no? This here. So this is the probability, assessing the probability of cancer, and the PET to assess whether there is to go for a biopsy or not. So now I'm showing you 3 images. Depending upon so you have to tell me how you will proceed to get a tissue diagnosis. This is the central location, and the second image is showing a peripheral location, and third one is abutting the pleura. So the first one, the central location, what investigation you will ask?
we can ask for a bronchoscopy and biopsy from the lesion.
Bronchoscopy and biopsy. Suppose the bronchoscopy is coming normal or no, and only an extrinsic compression, what will you do?
Then we will proceed with the CT guided biopsy.
This particular area, how will you approach the transthoracically here?
We can do an EBUS and take biopsy.
So what about this second one?
Second one, we can go with the CT guided biopsy, since it is.
What complication you will expect when you are asking for a peripherally located lesion, but surrounded by lung tissue?
Pneumothorax.
So before asking for a biopsy, what other important thing you will look into so that to avoid the complication, or before deciding this? Just now we were discussing about that.
Mediastinal staging.
Pardon?
Mediastinal staging we have to do.
No, we haven't got the biopsy report, the biopsy yet. So this is the lesion, and you want to put a needle from here, and that is going to travel through a normal small area of normal lung. You are going to pierce a normal lung. So what will happen if there is a normal lung? You will end up in
Pneumothorax.
pneumothorax. So before before putting the needle, what other things? Whether he can tolerate this procedure or not, whether the pneumothorax or not, because if his lung is so bad, his lung is severely, he's having severe chronic obstructive airway disease, then probably we cannot ask for a transthoracic biopsy. This is a fairly straightforward. Here, probably you can do a straight transthoracic biopsy on that. Okay. So, so this is these are the methods by which we can take the biopsy, either to do a what you as you said, the EBUS, or even sometimes in the more central lesions, one can do a even a endoscopic ultrasound guided biopsy. But the mediastinoscopy is one of the main investigation which helps. So in the case of central, do you still believe in sputum cytology or not?
Sputum cytology, we need a biopsy. If biopsy cannot be done, and the patient has very poor pulmonary function, then we can do a sputum cytology to start treatment. And the patient is very symptomatic, and if biopsy cannot be.
If the patient is, if we are not able to get a tissue diagnosis because the patient is having very severe COPD and you don't want to make a pneumothorax, then are there any ways of getting a diagnosis? Any of the newer methods?
Sputum cytology we can do, or
And other than
or we can do endoscopic EBUS or endoscopic ultrasound and biopsy.
but this is a peripheral lesion, no? So you cannot get. Or can you do a liquid biopsy in this patient for diagnosis?
Biopsy we can.
So what is the sensitivity and specificity of liquid biopsy?
Sensitivity is about 85%.
85%. Sensitivity?
I'm not sure.
Specificity is 85%, sensitivity is only 60%. So coming back to your case, Pallavi, so what other investigation you will ask for now?
We will do a CT chest, abdomen, pelvis, or we can do a PET scan. Then after that, that can be used for staging. If there are other metastatic lesions, it can be picked up in CT chest, abdomen, pelvis, or in PET scan. And it can also be used to assess the mediastinal and hilar nodes. But even if PET is showing mediastinal nodes, then we have to proceed with mediastinal staging.
In all cases, you will ask PET CT, or in selected cases only? Which is your preference? Is it a CT thorax or a PET CT, and why?
If we are proceeding with surgery, normally we ask for a PET CT.
Or we can put it in a
because it can identify metastatic disease.
A definitive treatment like surgery or a chemo radiation, then or you are expecting a limited stage disease, then probably your PET is a good investigation, right? So in advanced cases, do you want to do a PET CT or not?
In advanced cases, we can do a CT chest, abdomen, and pelvis. The patient is planned for palliative treatment, chemotherapy, or other treatment.
But in this modern era of different types of treatment, newer modalities of treatment, the comparison and the treatment response, studying the treatment response is a very important thing. So forget about the affordability and other things, but otherwise, even for the advanced cases as well, we will prefer PET CT, right?
We can take PET CT for advanced disease also.
So any other investigation you will ask before advising surgery? Suppose this is the PET is showing a limited disease and you are planning surgery. Any other investigation you will ask before planning surgery, before advising surgery?
NCCN recommends MRI brain from stage 1B.
So what are the limitations of PET-CT compared to the CT thorax?
And
Or what are the limitations?
PET-CT cannot detect brain mets.
It's not that
Nodal and increased uptake in nodes in PET-CT can also be due to inflammation or other
so
causes.
a lot of non-malignant conditions will also be picked up by PET-CT, and any other one more thing is considered as a very important limitation in the case of lung cancer. PET-CT. Subcentimetric lesions will not be picked up by PET-CT, so that is also a limitation. So the next question is in all cases you will ask for a MRI or only in limited cases, especially when a patient is limited resource poor or limited resources. How will you choose a patient for MRI brain?
In a limited resource, if the patient is symptomatic, we can do an MRI brain.
The patient is planning for surgery and we want to advise MRI or not. That is the main question. So are there any tips by which you can decide whether to ask for a MRI brain or will be satisfied with the PET-CT alone? Like the size of the lesion, the histology of the lesion, or any other.
Lung mets are more common in adenocarcinoma, and
you can avoid doing an MRI brain if there is a obvious mediastinal infiltration and the patient may be having a high volume disease. Second thing is, if the lesion is more than 4 centimeter, probably you can if it is less than 4 centimeter, probably you can omit MRI brain if there are limitations in the resources. Or in case of a squamous cell carcinoma, because adenocarcinomas are much more, there's a higher tendency for brain metastasis, but squamous cell carcinoma is not that brain seeking lesions. Why don't any other on PET and any discussion on PET?
Yes, sir. Actually, if you are planning for an actually radical type of treatment like surgery or the concurrent chemotherapy, then it's always better to do a MRI brain also. But if it is an already advanced disease and if the patient is asymptomatic for brain, then actually the MRI brain is not mandatory.
Some centers even ask for PET-CT before biopsy, because similar kind of situation where I told you that the patient has got a severe chronic obstructive airway disease, and it's risky for to get a tissue diagnosis from the lung. Then we can do a PET-CT to see whether any other extrathoracic lesions there to get the biopsy done. Okay, so these are some of the advantages and disadvantages. So it's the clinical situation which will decide, and also the site of the tumor, right? Site of the tumor is also very important in deciding the what investigation you will ask for getting the tissue diagnosis.
Sir, actually, our cases CT was not displayed.
Correct. Yeah. What was the CT findings, Pallavi?
CT findings, CT showed a 5 into 403 centimeter lesion in the right
Sir,
lower.
can you please change the slides?
This is PET-CT. So the CT findings same as PET-CT and
same as PET-CT, but there was no there was a high level also.
this patient has got lower lobe lesion, mass lesion
in the CT, it's a lower lobe mass lesion about 5 into 403 centimeter with a right hilar node.
So what is the clinical stage of this patient?
Clinical stages, CT to N1.
CT to N1. So what about the subcarinal node?
SUV 0.89.
Because the
Okay,
PET
so a suspected,
We have
suspected N2 node, right?
um,
So in that case, how will you proceed?
we have to do a mediastinal evaluation using an EBUS or EUS to evaluate or VATS to evaluate the subcarinal node. If then we can do a mediastinal scopy.
Pallavi, looking at the PET CT, what is the stage? So after Varun pointed out one thing, you want to correct your stage.
So according to this, then it is CT2 N2 disease. If mediastinal
What is T1 that you are staging? What is the T size? The T1 according to the T size, T1 is
CT2 and CT2 N2.
no. What I'm asking is how will what is the tumor, the T size? What is T1?
Yeah, Dr. Pallavi Sari is asking about the AJCC staging. What is T1?
Oh, T1 is less than or equal to 3 centimeters. T2 is more than 3, less than or equal to 5 centimeters. T
T1, T2. So T2 has got A and B.
T2 has got A and B. T2A is more than 3, less than or equal to 4 centimeters. T2B is more than 4, less than or equal to 5 centimeters, which is T2B N2 disease.
So T2B and 2.
N2.
And anything actually in addition to that, any infiltration to adjacent structures in T2?
Sir, I can't hear.
Yeah, in T2 staging, actually only the size wise, or actually are they mentioning anything about infiltration to the adjacent structures?
In T2, if there is involvement of a visceral pleural involvement, then it is T2. Or there is involvement of the lobar bronchi, but not reaching up to the carina. Or if there is atelectasis not reaching up to the hilum, then it is T2.
Okay. So T3, what are the special structures which are included in T3? Involvement of particular structures are considered T3. Like
T3 involvement of chest wall, then pericardium, phrenic nerve. Then if there is a then if there is a nodule in the same lobe as the primary, separate nodule in the same lobe as in the primary, and it is T3.
okay, so you have done a FNAC of this primary, and you got the diagnosis as adenocarcinoma, and it is for FNAC or Truchet biopsy, and then this is the diagnosis. So probably looking at the group staging, it belongs to T2B. That is T2B, and if we are taking the node as N2, then it will be stage
3.
Stage
3A.
Okay. Okay. So so you can further present this.
Patient underwent right lower lobe.
Sir, can you please go back to
Yeah.
the previous slide?
One more.
Yeah, previous one. Previous one. And Dr. Pallavi, actually, you have mentioned the biopsy reports are as adenocarcinoma. So can you diagnose an adenocarcinoma with a single IHC marker?
No, we have to do CK7, CK20, TTF1, NAPSIN. We have to do CK7 is usually positive, CK20 is negative, TTF1 is positive in about 75 to 80% of patients. NAPSIN is also positive.
In which other malignancies TTF1 it will be stained positive?
CA thyroid also it will be stained positive.
Yeah, apart from that,
in some small cell lung carcinoma also it may be stained positive.
yes. So actually it is really actually important to do IHC nowadays. And So what are the different histological types of NSCLC?
Histological types are adenocarcinoma, squamous cell carcinoma, adenosquamous carcinoma, then sarcomatous carcinoma, then large cell carcinoma.
How will you
Large cell
diagnose?
carcinoma is also called poorly differentiated carcinoma. And can you enumerate the IHC features of actually all this? Means small cell, non-small cell.
Adenocarcinoma, it is CK7, CK20, TTF and AMPSIN will be positive. Squamous cell carcinoma, CK56, P63, P40 will be positive. Then for small cell carcinoma, synaptophysin, chromogranin, CD, it will be positive. Then for a large cell carcinoma, CK7 will be positive, but it will not have a histology of either of adenosquamous or small cell. Then for sarcomatoid carcinoma, it is of 3 types: pleomorphic, then carcinosarcoma.
How will you diagnose adenocarcinoma, non-small cell carcinoma, not otherwise specified, NOS?
Yeah, or otherwise, actually, if you do the biopsy from a lung lesion, and if the IHC came as CK7 negative and CK20 positive, so how will you actually interpret that?
It might be a GI lesion with lung mets. We have to look
Then
for
which all additional markers you will ask?
we can ask for CDX, CDX, SAD-B2 we can look at. Then
PDX2.
CDX2, SAD-B2. Then you can see to rule out colony malignancies, we can check for that.
This is
Suppose
something we have
if it comes as CK7 negative, CK20 negative, then what are your differentials?
Then it might be from liver, prostate, renal cell carcinoma, etc.
Right.
For HCC, we have to do HEPAR1 and glypican. For prostate, we can do PDC. So I can't hear.
No, I think it's a disturbance from outside. We haven't asked any question. So you can tell us something about my previous question, like non-small cell carcinoma NOS.
Non-small cell carcinoma, if it is
not fitting into any of the ISC markers and the CK7 is positive, then we will call it as carcinoma, non-small cell carcinoma, NOS. So in that case, what will you do?
then
How will you proceed further? Because the ISC will not help you, and the pathologist is not able to tell you that this is what is the subtype of non-small cell carcinoma. Sometimes it will be very, very difficult. So what will you do in that difficult situations?
then we can do a PET CT, and we can.
We have already done, Pallavi. We have already done that, and we have taken a biopsy, and the biopsy is reporting as non-small cell lung NOS. So you may have to do a repeat biopsy and to start chemotherapy. Then, based on the final report, you have to change your approach. So why don't can we go to the
Yes.
how she approached this problem? Let us see how she approached this problem. And what did you advise to this patient?
We advise repeat biopsy for the patient, and the patient is willing, we can do a repeat biopsy, and we can.
We are asking about your case, and we have. Can we go back? What did you do with this patient after the diagnosis? Now we have a PET done, and the PET staging is stage 3 A, right?
3A.
So what advice have you given to this patient?
We ideally have to proceed with mediastinal staging because to confirm the presence of mediastinal nodes. So if it is, we can go with surgery if it is if it is a single N2 node, and if it is not a conglomerate mediastinal node. So in that case, and if the mediastinal nodes are negative, then we can do just a mediastinal node sampling during surgery. If it is positive, we have to do a lymph node dissection. So we ideally have to do a mediastinal staging first, and before we
Dr.
proceed with
Pallavi,
surgery.
actually, yeah, Dr. Pallavi, apart from the mediastinal staging, before surgery, what is the important thing that you left out here?
Pulmonary function test.
Yeah, but what do you mean by physiological staging? What are the important things that we look into that in physiological staging? 2 important parameters. It is FEV1 and DLCO.
DLCO.
And so by IVR at checking all those things.
If FEV1 and DLCO is more than 80%, then he's a low risk candidate.
Yeah, to predict the postoperative pulmonary function. So that is the most important thing. So whether the patient can withstand a lobectomy or a pneumonectomy or a sleeve resection, so that is mainly to predict the postoperative pulmonary function of the patient. Suppose an early lung lesion, it is easily resectable, maybe stage 1B, but the patient's pulmonary reserve is very poor. Yeah, 3 centimeter lung lesion, and it is diagnosed as NSCLC. Then what are the options left to us?
We can do a wedge resection or segmentectomy. Segmentectomy is better because
no, if the patient is not an operative candidate, if he is not a surgical candidate,
an operative candidate, then we can go with a radical RT, SPRT. We can do.
So, Pallavi, you talked about the mediastinal staging. So, what important lymph node stations you will be looking at during your mediastinal staging? Especially your patient has got a right lower lobe lesion. So, what particular level of lymph nodes, according to the PET-CT, you will be looking at, and as well as thorough mediastinal staging should look into these levels of lymph nodes. So tell us about that levels of nodes.
For right-sided tumors, we have to look at mediastinal stations 2, 4, 7, then 2, 4, 7, 10.
Do you like the toys?
Can everyone be on
The sand train wreck? Yes.
Okay, I made it. Ashim, just mute the mics if possible.
So, Pallavi, can you just tell us about this staging, this mediastinal lymph node stations? You are talking about the right-sided tumor, and at least which all stations should be, just for the sake of getting the different lymph node stations. I have put this image. So you can just tell us which all lymph nodes are important for a right-sided lesion of especially your patient has got a right-sided lymph node.
For right-sided lesions, that is stations 2 and 4. That is a upper and lower paratracheal nodes.
This is basically lower lobe lesion, Pallavi. So at least 2 lymph nodes, because you cannot take the whole lymph node stations.
So 4, 7, and 10 should be looked at.
4, 7 and 4, 7 is very important. So, so that's coming back to your biopsy report. So this is your biopsy report after the surgery, right? So tell us something about the report.
The histology report came as adenocarcinoma lung. Tumor size is 4 into 3 into 3.5. centimeters. So, but it is focally infiltrating the pleura. So, so it becomes a PT3 lesion. The resected margins are free. Interlobar node shows metastasis. That is a hilar node. That is only one. And subcarinal node, mediastinal nodes were also resected, and that only shows reactive changes. So it is still N1.
Do you want to clarify anything from this biopsy report? Varun?
Yeah, actually, you didn't mention about the pleura. Is it a mediastinal pleura or a parietal pleura? Because that depends upon the staging will change, right? So is it a mediastinal pleura or a parietal pleura?
Parietal.
So suppose if it is a mediastinal pleura, then what would be the stage?
Then it will be PT2N1.
Yeah, then it will be a stage 2B malignancy. So that's why actually this interpreting pathology report is really important.
So looking at the tumor size, what do you think that the patient has got PT1 or PT2 or a PT3? Because you have written as PT3, is it a PT2 or a PT3?
Based on tumor size alone, it is a PT2.
PT2, yeah. PT2 N1 because subcarinal nodes were all negative or showing only reactive changes. So do you want to revise your staging after the surgery? So this patient has got a tumor of 4 centimeter size, so it belongs to T2 PT2, and since the only interlobar node became positive, we have to restage as
2B.
PT.
Sir, actually, no, if the parietal pleura is involved, then actually it will become T3, sir.
T3, okay, right. So only at looking at the tumor size.
Yes.
Okay. So how will you? This is in nutshell about the mediastinal staging. And if the mediastinal staging, suppose now the N2 is negative, so a patient has got stage PT3 N1. So group
Stage
stages.
3, yes, sir.
Group stages.
3A. 3A.
3A. So what further treatment you will offer to this patient? What would have been the best option had it been diagnosed earlier, like before surgery?
We could have given neoadjuvant immunotherapy followed by
Neoadjuvant immunotherapy. Why neoadjuvant immunotherapy?
neoadjuvant chemotherapy followed by surgery.
Only chemo, or you will give chemo plus radiation? Which is better?
Neoadjuvant.
Pallavi, actually, is it a standard to give neoadjuvant chemotherapy?
No, we
In
usually
withdrawal settings, you will give the neoadjuvant chemotherapy in lung cancer.
if it is a large tumor, usually
If
we
it's a
give
bulky N2, if it's a bulky N2, what do you mean by bulky N2? Is there any size cutoff for that?
Multi-station N2 also.
bulky into is multiple mediastinal or conglomerate mediastinal nodes more
Yeah,
than
any size cutoff?
more than 2 centimeters.
Yes. And is there any trials or is there any recommendation for giving
Neoadjuvant immunotherapy with nivolumab, there is a trial. Checkmate 816 trial is there.
immunotherapy alone?
No, immunotherapy with chemotherapy.
Yes.
Okay, so since the patient has completed surgery, so what other option you will, what adjuvant treatment you will offer?
We have
Any biomarker you will be testing at this point of time?
We have to see the EGFR and PDL1 status.
Early, since this is an early lung cancer, do you want to do the biomarkers? Because biomarker-driven treatment is basically we will more of a metastatic disease. So do you think that doing a biomarker at this stage will help the patient in deciding your treatment?
If EGFR is positive, then there is from stage 1B to 3, there is recommendation for giving consolidation osimertinib for 3 years based on the ADORA trial.
Okay, so you will be asking for EGFR mutation. So you will be the only EGFR mutation or the full panel you will be asking like the ALK, ROS and
We can ask for the full panel, but only data is only on osimertinib.
so the data is only for the EGFR mutation. I know.
Mhm.
Is there any need for a PDL1 as well?
PDL1 also we can ask for, because there is the IM power IM power 010 trial for atezolizumab, adjuvant
power?
atezolizumab
010 yeah.
for atezolizumab,
Adjuvant atezolizumab.
adjuvant atezolizumab.
Adjuvant atezolizumab. So based on or will you advise chemotherapy as well in this patient or you will,
Yes,
since the-
chemotherapy 4 cycles followed by adjuvant atezolizumab till 16 cycles, 1 year duration.
but you are
So Dr. Pallavi, so what is the rationale of giving the adjuvant chemotherapy in lung cancer?
The rationale is behind the LACE meta-analysis, which proved that overall survival was increased by 5.4% at 5 years when chemotherapy was given, based on a meta-analysis of 7 trials. And
Or can you mention actually the 5-year survival of lung cancer by stage wise? The stage 1, stage 2.
Stage wise for localized disease, it is almost 60%. With midestone node involvement is 30%.
No. I'm not asking about that trial. I'm asking about the survival of a lung cancer with stage 2 or stage 3, the 5-year survival.
Okay.
Without treatment.
Stage 1 is 70%. Stage 2 is 50%.
Stage 1 is 70%.
Stage 1 with treatment is 70%.
Yeah, I think it ranges up to 80%. Yes, 70 to 80%.
you are talking about chemotherapy or the
No, sorry. Actually, in a case of lung cancer, what is the survival of a patient? That is 5-year survival of a patient.
correct. Yeah. So what is the
Then
survival?
stage 3B patient,
Stage 3 is 20%.
3B.
20
Stage
to
3B is 20%, and stage 3A is much better than that.
30,
Yeah, I think it's around 30%.
30%.
So this is the in nutshell you have what you have described for early stage like adjuvant. You have to do EGFR and PDL1. At the moment we have data evidence for this. So this is what you are talking about. So what is the benefit of the chemotherapy in the LACE meta-analysis? Did you answer this question, Varun?
Yes, sir. She answered that question.
Okay. So the benefit is like this, stage 1B. So which all the stages you will advise adjuvant chemotherapy?
There were significant benefits seen in stage 2 and 3, but in stage 1B patients with certain high-risk features like size more than 4 centimeters, poorly differentiated histology, vascular invasion, inadequate lymph node staging, and if only a better resection is done, then we can advise adjuvant chemotherapy.
So
For this,
clearly, the stage 1A is out from the adjuvant treatment, the indication for adjuvant treatment. So basically, stage 1B onwards, patient can be treated with the adjuvant chemotherapy, and the magnitude of benefit is already discussed. And this is about this is what you have mentioned about the chemotherapy and the ADORA trial, and what is the benefit of again the ADORA the osimertinib in different stages? Can you tell us what is the benefit in the stage 1, stage 2, and stage 3 disease?
stage
All stages will be having the same benefit or it is different?
benefit was seen more in patients in stage 2 to 3, more than in stage 1B, with osimertinib.
So can you tell me the figure, what percentage of patients, or what is the magnitude of benefit in ADAURA?
Um,
So this is the benefit, and though all stages are benefited, but the majority benefited was stage 3
yes.
and stage 2, and this is the benefit. Okay. So I don't know anything you want to add further, because we are just completed our allotted time, and we can have 1 or 2 more questions, and we can get some opinion from the audience.
Yes, sir. Actually, I would like to ask about the EGFR testing because it's an EGFR positive lung cancer. So which are the techniques that is mainly used for testing this molecular test?
We can do NGS, RT-PCR, Sanger sequencing can be done for EGFR. Test.
So what is the difference between, or what are the benefits of doing NGS when compared to PCR?
In NGS, multiple genes can be tested
Okay.
at the same time. Many mutations can be tested. Then,
apart from that,
then we can know the type of mutation, if it is exon 19 deletion or 21 mutation, or T790 mutation, that we can do NGS.
then anything else?
Then,
what is the advantage of NGS over conventional PCR or Sanger sequencing in detecting EGFR mutation? That's the basic question.
Yeah, Pallavi, actually, one thing as you mentioned, actually you can evaluate the multiple genes simultaneously. The other thing is that it retains its sensitivity even with a lower tumor content. So it is actually particularly important in lung cancer because the specimen is very important for us. And the other thing is that actually we can do the parallel sequencing, or we can do even the all exome sequencing we can do.
So which will miss PCR among the EGFR? Which mutation is likely to be missed in PCR method? Exon 20 mutation.
20 insertion can be missed.
Insertions will be missed out in PCR, but it will be more picked up by NGS. That is the main advantage. So you will not be missing any mutation at all. So having said about this patient, it was positive for EGFR. So can you try gefitinib or erlotinib, because the patient can afford only these two. So will you advise gefitinib or erlotinib in this particular patient?
Gefitinib and erlotinib has been compared with chemotherapy, not as a consolidation, and the results have varied. Some trials have shown improved DFS, but none of the trials have showed any. And
so is there any ongoing trial?
Ongoing. For gefitinib, there is the impact trial, then adjuvant trial.
Have you heard about Alchemist trial?
Alchemist trial, Alchemist trial, erlotinib is being evaluated in Alchemist.
Yeah, only erlotinib?
Crizotinib and nivolumab.
Yeah, both EGFR and ALK they are evaluating. So suppose if it is a metastatic lung cancer, so which are means molecular test you will order?
If it is metastatic lung, we will do EGFR, ALK, ROS, MET, RET. Then BRAF we can do, PDL1. KRAS also we can do.
Why KRAS?
Varun, 1 second.
KRAS.
How long you will continue osimertinib when you are giving it as a consolidation following?
3 years.
So what are the problems when you are giving osimertinib for 3 years? And what was the major observation made in the ADAURA trial, which which is very, very clinically relevant, which one has to discuss with the patient.
Resistant mutations can occur.
More than 20% of the patients compliance was a major issue because of the toxicity, and the people have refused to continue beyond 12 to 18 months because of the toxicity. So continuing for 3 years osimertinib is a big challenge, and almost 20% of the patients couldn't continue beyond 18 months. That was it. So this has to be discussed with the patient when you are starting an adjuvant osimertinib.
So Dr. Pallavi, in a case of metastatic lung cancer, EGFR positive, what is the magnitude of benefit with the first generation, second generation, third generation EGFR inhibitors?
Okay, I got the message from Arun reminding me about the time, since we were totally immersed in the discussions and the questioning, and Pallavi was answering very well. I think the evaluation Pallavi has done really well. What do you think, Arun?
Yes, sir.
She has really done well, and we have
apart from small glitches in the history part, actually, otherwise she did well. But in the history, actually, I think you should give more importance because if you present a good long case in an exam, it is half done.
Okay, she could have included more points in the history as in the examinations.
But what things I noticed in the history is that actually she mentioned that actually, with the history of cough only, actually a physician from periphery referred the patient to a tertiary care cancer center. It is very hard to believe because without taking an X-ray.
They took PET CT from outside. Then
yeah.
So I think we will stop here, and thank you, Pallavi. Thank you, Varun, for joining. And we will wish her all the best for her exams. And once again, thank Ampok members for this opportunity, and looking forward to more such opportunities in future as well. Thank you, Arun, and thank you, Bobin. Over to Arun.
Yeah, Arun.
Bobin is there.
So to face the barrage of questions and come out. So I think it's been done quite well. So thank you, sir, and thank you, Varun, for enthralling us. I think we'll close it over here, and we'll plan the next session next month. We'll plan for an external examiner and one from outside Kerala, one from inside Kerala, try to mix things up also this time. So thank you all for your patient listening. If Bobin sir is there, any closing remarks? Okay, I think sir has taken leave. So thank you once again, and thank you everyone for attending. Thank you.